Hello, everybody. My name is Rebecca Go-Oco, and I'm working with Desiree. We're going to present this week's topic of investigative therapies on allergies and infectious diseases. So, allergies are an overreactive response of the immune system to a substance that is not normally considered harmful. This can be a food allergy or a drug allergy or even an overreactive response to an environmental pollen, such as house dust mites in the house or seasonal um, shifts in the weather, which causes pollen to flow through the air and can stimulate a response that is not favorable within our body. While infectious diseases are caused by microorganisms that enter the body, such as bacteria, viruses, parasites, or fungi. These diseases can be spread either directly or indirectly from different sources, such as person to person contact, animal to human contact, or vectors. This also includes contaminated water, contaminated food, and let me pause that. And the list of diseases within this category, um, the National Institute for Allergy and Infectious Diseases, or the NIAID, works at supporting research dedicated to curing um, diseases within this scope. So, the common list of diseases within this category of allergies and infectious diseases include AIDS, asthma and allergies, re-emerging infectious diseases, enteric diseases, tropical diseases, influenza, among others. So the general epidemiology of this category, there are several types of allergies. Three main types are allergic rhinitis or hay fever, drug allergies, these are adverse drug reactions to medicines that one intakes, and food allergies. Allergic rhinitis affects about 7.5% of the total population, and there seems to be a racial disparity among the prevalence of allergic rhinitis in individuals. Paler skinned patients seems to be more susceptible to acquiring allergic rhinitis. Um, drug allergies or adverse drug reactions take place in about 1 in 10 people worldwide, and food allergies they affect quite a lot of people. About 8% of children in a study of 40,000 participants suffered from a single food allergy, while about 30% of those 40,000 participants experience more than one food allergy. In infectious diseases, this encompasses all diseases that take place as our body's immune system responds to a foreign agent and looks towards addressing new and old re-emerging diseases. Currently, research is being done to look at the spread of re-emerging infectious diseases. So, we are currently looking at complementary therapies that will help assist in curing infectious diseases or allergies. Two main points that come up here are probiotics and phytomedicine. Common alternative therapies for this category of diseases include probiotics to assist with a better immune and gut system for the individual. Another popular therapy includes phytomedicine, and these include plants and herbal remedies. So for the first disease of this category, um, I will be talking about atopic dermatitis and two complementary therapies that I've researched that can be beneficial for this. What is atopic dermatitis? So I will be abbreviating this as AD. So AD is a common chronic disease characterized by itching and dryness of skin. This is commonly caused by a damaged skin barrier, either through wounds or infections such as bacteria that have taken host upon the infected area. Atopic is derived from the Greek word strange, and dermatitis can be separated to define each term as derma meaning skin and itis meaning inflammation. Literally speaking, AD would be defined as the strange inflammation of the skin. So signs and symptoms of AD. The signs of AD do not differ too much from signs of eczema, which is also a disease characterized by itchiness and dry skin. However, while this term is commonly interchanged with dermatitis, this presentation I will be differentiating between the two. The Greek term eczema means to boil over, and AD in this presentation is different from eczema or atopic eczema, and this is mainly due to how AD occurs in an individual. While there is no universal standard term for the word atopy in this sense, this usually applies to an inherited tendency. In AD, the inherited tendency is for the body to produce immunoglobulin E or IgE antibodies in response to small amounts of allergic factors, in which AD forms the atopic triad of asthma, hay fever, and AD. Now, the symptoms of AD are similar to eczema, and diagnostic criteria has been created in order to determine the several features present in this disease. Essential features include itching and morphology of eczema such as the elbow or the knee. The severity of AD can be measured using a scoring system called Severity Scoring of AD or SCORAD. While there are common signs of AD per age group, the typical manifestation of this are dry skin or xerosis and paler skin tone of the infected area due to the increased tension of skin capillaries and reduced ability to sweat. There is also an inherent need to scratch at the infected area. So, current conventional treatment of AD. Currently, um, treatment for AD aims to either minimize the number of new manifestations, this focuses more on the prevention of AD, or reduce the duration and degree of already existing manifestations of AD on the individual, and this focuses more on the management of AD. Common or conventional treatments that are present today include emollients such as moisturizers and lotions that help protect the skin barrier from the outside, influences, as well as provide moisture to the dry area to avoid itchiness. Another would be topical corticosteroids, which are divided into classes depending on the strength of the medication and they are the common to-go treatment for AD. Another treatment that's popular are calcineurin inhibitors such as pimecrolimus cream that assist in the treatment of the flaring of AD and its maintenance therapy. However, side effects such as skin thinning may prove to be a hindrance in therapy for some individuals, which is why alternative therapies are available, and here are some suggestions on the image on the right side. Um, Complementary therapies have been commonly described as a treatment or prevention that complements mainstream medical therapies. In AD, the use of complementary therapies can mean a variety of treatments, two of which will be discussed today. Examples of such do include herbal preparations, probiotics, fatty acids, and acupuncture. Um, this table on the right. So the epidemiology of AD. The prevalence of AD has increased over the past few decades, so much that the term allergic epidemic had been coined. As this is a common health concern, it has been reported that about 50% of all cases of AD have developed symptoms throughout the first few months of infancy, and about 95% of individuals today with AD have experienced this onset when they were at least 5 years old. Several adults who have AD today are experiencing recurring onsets of AD that has occurred to them previously as a child. Determinants of AD include sensitivity to allergens such as house dust mites, food allergens, and others. Risk factors also include internal factors such as genetics, where the occurrence of AD in an individual is higher in those who have a family history that also experienced AD. About 50% of the children who experience AD are also likely to acquire asthma, while about 75% of this population are also likely to acquire allergic rhinitis or hay fever. This is what forms the atopic triad. A common external factor is the hygiene hypothesis, where those who are less exposed to common allergens as an infant are more prone to atopic diseases, which is prevalent in more developed countries as exposure to allergens are limited. So there are several costs to AD, and one of the that AD can burden an individual or one's family with are financial costs, including physician visits, prescription meds, and emergency hospital costs. There has been at least 75% of patients reporting at least one visit to the doctor regarding an AD specific symptom in 2015. In 2006, the American Academy of Dermatology and the Society for Investigative Dermatology looked into the costs of AD and related skin diseases, and direct costs were projected at about 1 billion, with indirect costs reaching up to 3 billion without including the cost of over-the-counter products. The family burden with children that have AD include the emotional frustration and exhaustion that comes with taking care of young children that suffer from AD. This leads to reduction in the overall well-being of the provider as well as the patient, and only grows when the individual becomes adult to experience AD. Besides the financial burden that AD places on an adult, individuals may also experience mental health effects such as anxiety and insecurity due to the occurrence of AD on their skin. This may lead to additional stress, decreasing the productivity and work efficiency of the individual. So for the first natural product to address AD, I will be talking about probiotics. So what are probiotics? These are live microorganisms that may be similar or the same as microorganisms present in one's gut microflora. In our gut, these microorganisms help promote healthy digestive systems as well as our immune health. And traditionally, probiotics have been used to help stimulate the growth of the healthy gut in one's digestive system. And how is it used for AD? Probiotics look toward working on the immune system development of an individual. The presence of health bacteria such as lactobacillus contributes to regulating the allergic hypersensitivity reactions of the Th1 and Th2 responses by increasing the regulatory T cell response. So my first study, entitled No Effects of Probiotics on Atopic Dermatitis in Infancy, a randomized placebo-controlled trial. This study looked at a 3-month intervention of two intervention groups compared to the placebo. The first intervention group was Lactobacillus rhamnosus, and the second intervention group was Lactobacillus GG. The participants were infants who were suspected of a cow's milk allergy, and they were exclusively formula fed from the onset of the study to the study end. The results illustrated that there were no statistically significant effect of the intervention of probiotic bacteria to the SCORAD measures, sensitization, or overall inflammatory parameters of the participants. So this study concluded that there was no clinical or immunological effect of probiotics to infants with AD. One of the limitations present in the study was that there was no statistical between group analysis performed to compare intervention with the control group, as these measures were measured as a group but was not compared before reaching a conclusion. The second study looked at a 3-month intervention trial with three intervention groups: Lactobacillus paracasi, Lactobacillus fermentum, and a combination of both. This this study also measured SCORAD scores as well as immunoglobulin E levels, among others. And while all three intervention groups did lower the SCORAD measure compared to the placebo group, this was noted to be statistically significant. Another note to mention was that um, that measurements were taken also post-treatment, about 4 months post-treatment, and these participants that were part of the intervention group still illustrated lower SCORAD scores than the placebo group. A limitation of the study was that it was a large gap of children. We had infants, toddlers at a year old, to participants that were up to 18 years old. The third study that was researched with regards to probiotics as an alternative therapy. This had a shorter duration compared to the previous two trials and looked at probiotic supplementation over the course of 12 weeks. There was a significant difference between the control placebo group and the intervention group. This study looked at the eosinophil count as an indicator for disease activity, and the intervention group was measured to have a lower eosinophil count, indicating a lower disease activity level in that group. The study then concluded that the use of probiotics as a supplement does assist with the treatment of AD. Now, looking at the three studies, you can see that the duration of the study looked to be about the same, from ranging between 3 to 5 months. The dosage method, however, was different. Um, you can tell that the second study, with the combined mixture of lactobacilli, had a larger dose, and the last study, study 3, had the largest dose out of the three. Um, they were all determined to be safe to use. There did not seem to be any adverse effects reported by any of the participants, and you can tell that the studies all ended on a different note. The first study would claimed that this was not an effective therapy, while the second study said yes, and the third, yes, but not statistically significant, and the third study said yes, this was significant. Um, you can tell that based off this table, I would like to say that the study 3 was proven to be effective because of the amount of intervention consumed by the participants. You can tell looking at the number um, on the table that they did consume the highest amount of bacilli each time they consumed it throughout the study. As probiotics can also be found in food, it is not a surprise that this is safe to use. My recommendations for this will be found after the second therapy. So the second therapy would be borage seed oil. What is borage seed oil? This is oil, an edible oil that is rich in gamma-linolenic acid or GLA. This is also known as star flower oil and is known to have higher concentrations of omega-6 essential fatty acids compared to a common alternative therapy called primrose oil. Essential fatty acids cannot be. This first study looked into the application of borage oil in expectant mothers and their child during the study period. Mothers were placed in an intervention group of borage oil and a placebo group of sunflower oil. When this child was born, they were also given supplementation, and this was continued up until the infant was 6 months old. Results illustrated that while the supplementation of GLA did not decrease the expression of AD, the severity of AD as it occurred in the infant was decreased. For the second study, they looked at a wider population age range and the application of borage oil at appropriate dosage for over a 12-week period. While the treatment groups did have a decrease in the measures used to look at the severity and symptom scores of AD in these participants, there was no significant difference between treatment groups. The study noted that as of the point of their publication, the study looked at the highest dosage of GLA in their participants, and this was well tolerated. The third study. While this study had been taken quite a while ago, there has not been much recent changes in the advancement of borage oil since then. Besides the previous two trials, this study looked at the supplementation of patients with 500 milligrams of borage oil compared to a lipid placebo group over a 24-week intervention period. This study was concluded to have contradictory results, as significant changes were seen in participants who were not strictly adhering to the criteria set out by the researchers. It has been concluded that research regarding specific subgroups should be looked into to determine the actual effectiveness of borage oil in the treatment of AD. Now, looking at all three studies in one table, you can tell that there has been a range of um, a duration of a study trial. So we have the first and third studies taking about the same amount of time, while study 2 took half the time at 12 weeks. The dosage method was different for each study, with study 1 supplementing the mother before giving birth, as well as the baby after birth up to 6 months old. The second study looked at a range of adults and children, and children took half the amount of oil and compared to adults. And the study 3 showed that all participants all took 500 milligrams as part of their intervention, and all of them were marked as safe to use, while with no adverse effects present except for the second study, as they have recorded um, inside the article, they have a table recording the side effects felt by more than one individual in both the placebo and the intervention group. And out of the symptoms recorded, abdominal pain had more cases recorded than the placebo group out of the symptoms that were listed. Now, were they effective? The first study that interviewed the mother and the baby were concluded to be effective in decreasing the severity of AD at the onset. Although this did not decrease the occurrence of AD, the severity of AD was, and the study concluded this to be a significant trial. The second study did not conclude this to be significant, and the third was inconclusive, as those that had a significant result did not strictly adhere to the criteria set out by researchers. Now, what would I recommend? Looking at both therapies that were researched for AD, looking at probiotics and borage oil, I would recommend using probiotics as to add for overall immune health. While I would not personally recommend the use of borage oil, I would instead suggest them to either look at a dietary change by increasing the amount of essential fatty acids in their diet, or taking omega-6 capsules, as there has not been enough research into borage oil for me to be comfortable prescribing this to an individual. Now, the recommended dosage of these therapies, for probiotics, as this can be found in foods, I would first ask them to incorporate this in their diet. Fermented foods such as kimchi and sauerkraut, and yogurt with live cultures is a source of probiotics that I would recommend before taking a capsule or a medicinal supplement. And as these are both safe to use, there were different levels of each therapy being presented in the studies that were the studies illustrated earlier. It No toxicity level has been reached, so this is safe to use. Um, Although I would recommend consulting a nutrition or other health professional or healthcare provider before thinking of consuming a larger than normal amount. Um, and overall, are these therapies effective? Yes, but they're not significant enough for one to recommend them as a first, what do you call that? A first way of curing or preventing AD. You can tell that these therapies do try to address deficiencies present in an individual, be it the gut health microflora that will be needing um, more colonies of healthy bacteria such as lactobacilli, or the skin structure deficiency of the lack of fatty acids. So while these are both the natural therapies that may be helpful, my first overall recommendation to clients that would, with AD, if they were to ask me and get my opinion, would be to look at possible dietary changes first. Here at the back of my presentation are references that have been used. Footnotes are also found at the bottom of the presentation slide, as well as numeric references to the sources used throughout the presentation. Thank you. Last few. Slides. And
Hello everyone, this is Desiree Legaspi. Thank you for viewing my presentation. I decided to research influenza as my disease. I chose this because it is very common, especially here in Chicago as we approach the winter. So let's dive into some of the promising alternative therapies. Influenza, commonly referred to as the flu, is a contagious viral disease that is easily transmitted. It affects the nose and throat but can often spread to the lungs, leading to further complications such as pneumonia, sinus infections, ear infections, asthma, and in some cases, death. There are several types, but the type I am focusing on in this presentation is types A and B, which is also known as seasonal influenza. The flu virus is passed between hosts through droplets which leave the mouth or nose when people talk, cough, and sneeze. In some cases, flu viruses can be picked up from surfaces and can lead to infection if that person then touches their nose or mouth. Symptoms of the flu include fever, sore throat, cough, runny or stuffy nose, fatigue, muscle or body aches, headaches, and sometimes vomiting and diarrhea. Influenza is tested by swabbing the back of the throat or inside of the nose and testing for viral infection. It's often done using rapid molecular assay that can provide a diagnosis in as little as 15 to 20 minutes. There are more accurate tests than this, but these often require laboratory access. Treatment of the flu usually consists of an antiviral medication that is only available by prescription. Common antiviral medications include oseltamivir, which is Tamiflu, or zanamivir, which is Relenza. And the most common side effects of these is usually nausea and vomiting. Pain relievers, fever reducers, and nasal sprays are often used in conjunction with or instead of antiviral drugs, along with rest and preventative measures to reduce further infection of others. The flu vaccine has also become one of the greatest successful preventative measures. Other methods of prevention include leading a healthy lifestyle, frequent hand washing to prevent spread and or contraction of the flu, and avoiding others who are sick. There are many alternative therapies for the treatment of influenza. This is a table which lists the most common ones that I came across. There is little evidence to support almost all of these. However, the two I'm going to focus on is echinacea and elderberry, which seem to have some promising preliminary evidence. I will go into more detail about these two therapies later, but you can feel free to pause the video here if you would like to read through the information about the ones listed. Okay, so a little bit about the epidemiology of influenza. Seasonal influenza affects the entire world. In the US, it is more prevalent in winter months. This is about November to April is when it's most rampant. The flu can affect anyone, but it is more common in children and the elderly due to their decreased immunity. It affects about 5 to 10% of adults and 20 to 30% of children. Globally, the flu results in about 25 million illnesses per year, 11 million medical visits, and over 300,000 hospitalizations. The CDC reported 12,000 deaths from pneumonia influenza, with 5,250 which occurred in the U.S. Although influenza is typically not considered fatal, further complications such as pneumonia, respiratory infections, and cardiac arrest are usually the end cause of mortality. The at-risk population includes children under 5 years old, especially those younger than 2, and the elderly over 65. Pregnant women are also at increased risk up to 2 weeks postpartum. And finally, individuals with certain medical conditions can be at more risk, including those with impaired immune function, respiratory diseases such as asthma and COPD. Monetary costs of influenza are astronomical due to medical visits, hospitalizations, medications, and missed work. The total economic burden of influenza is $11.2 billion, with $3.2 billion of that from direct medical costs and $4.2 billion coming from potential lost earnings due to the 20.1 million days of lost productivity. I obtained this visual from the Centers for Disease Control website. This is an influenza virus. As you can see on the outside of the virus, there are two main proteins, the hemagglutinin protein and the neuraminidase proteins. These are the proteins that determine the strain of the virus when you hear H1N1 or H5N1. Also on the surface of these cells is M2 or matrix protein that acts as channels for RNP or ribonucleoprotein to enter the host cell once the virus attaches to the lipid bilayer. To attach to the host cell initiating infection, the hemagglutinin proteins bind to sialic acid receptors on the surface of the host cell. Once attached, the virus can then enter host cells through endocytosis. The influenza virus is only equipped with negative sense single-stranded DNA and must reach the nucleus of host cells to replicate. Once replication occurs, the virus can then bud and cleave, multiplying so it can infect the respiratory system. In some cases, the virus can spread beyond the respiratory system, leading to pneumonia or further infection. Here's another couple of helpful images. This first one is a flow chart that demonstrates a little bit what I just said. And then the next one shows a little bit of the inflammatory process. So once influenza begins to infect the body, activated macrophages causes a release of pro-inflammatory cytokines such as natural killer cells, neutrophils, interleukin cells, and T helper cells. These pro-inflammatory cytokines cause inflammation to occur in the affected areas. These processes lead to the early onset of flu symptoms such as pain and fever. In response, the body uses anti-inflammatory cytokines to down-regulate pro-inflammatory processes. Therefore, anti-inflammatory diets and therapies can be useful in the treatment and prevention of inflammation. The first therapy I reviewed is echinacea. Echinacea is a flower native to Northern America. Native Americans used it to treat a number of afflictions such as cold symptoms, wounds, headaches, snake bites, and toothaches. Today, people often use it to treat the common cold, flu, or for immune support. There is some evidence to support its efficacy, but there is not enough. This is mostly concerning when considering the safety of its use, especially by children and pregnant women. However, it is generally considered safe when used temporarily as an alternative therapy. Echinacea is sold as express juices of the aerial or root part of the plant, hydroalcoholic tinctures, extracts, dietary supplements such as capsules, lozenges, or in the form of tea. There are three major types that are commonly used today: Echinacea purpurea, Echinacea angustifolia, and Echinacea pallida. Since echinacea is a flower, also known as the American coneflower or red sunflower, those with allergies to similar flowers of the daisy family or ragweed allergies should not use echinacea. This first study is a randomized double-blind controlled experiment. Researchers considered the use of an echinacea-based hot drink as an alternative and more natural therapy in treating the flu. It was compared to oseltamivir, a common antiviral drug used to treat influenza. Subjects of this study included 420 patients who began presenting with early influenza-like symptoms. They were recruited from 29 general practices in the Prague area of the Czech Republic from 2011 to 2013. They were then randomly and evenly assigned to the experimental group or control group. Group 1, the control group, received 5 days of oseltamivir followed by 5 days of a placebo. The medication was administered via hard gelatin capsule containing 75 milligrams of the Tamiflu and cellulose containing placebo capsules. They were also instructed to follow a regimen of echinophorus hot drink of 5 milliliters dissolved in 150 milliliters of hot water 5 times a day for the first 3 days, followed by 3 times a day for the remaining 7 days. Echinophorus hot drink is a formulation of active echinacea and elderberry in dosages of 1,140 milligrams and 1,383 milligrams, respectively. Group 2, the experimental group, followed the same regimen of the echinophorus hot drink with a placebo instead of the oseltamivir daily. Rescue medication use and daily symptoms were recorded in a diary and evaluated by researchers. Remaining medications were also collected at the end of each trial period and recorded. Only participants who consumed at least 80% of the provided medications were included in the final data, while those who consumed less were considered lost to follow-up due to lack of compliance. Results of the study showed no significant data to suggest that one treatment method was more effective than the other. Data collected for various measures continued to be insignificantly different. This suggests that Echinophores hot drink, if taken on its own, is as effective as the commonly prescribed antiviral medication oseltamivir. However, the difference between treatment options of note was in adverse events. The group who took the oseltamivir was 5 times more likely to have side effects and further complications, suggesting that Echinophores hot drink is a safer alternative. The study supports the use of Echinophores hot drink as a viable treatment option for the flu. Data suggests its value against influenza to be as effective as mainstream treatment, with less adverse side effects and lower incidence of further complications. The second study I reviewed is another randomized double-blind placebo-controlled study. The purpose of the study was to test the use of an echinacea compound herbal tea as an effective treatment in reducing the severity and duration of flu symptoms and other respiratory infections. The subjects of this study were 95 mostly female employees of Rest Haven York Nursing Home. They presented with early flu symptoms, and those who were allergic to coneflower or pregnant were not allowed to participate. The subjects were evenly and randomly divided into an experimental and a control group. The experimental group received echinacea plus herbal tea to drink 5 to 6 times per day, reducing dosage by 1 cup per day for 5 days. Each tea bag was the equivalent of 1,275 milligrams of dried echinacea herb. The control group received a placebo product called Eater's Digest tea to follow the same regimen. The tea was of similar flavor and look, but would have no effect on symptoms. Participants completed a scaled questionnaire 14 days after they began the program. The questionnaire consisted of 3 questions which referred to the effectiveness, duration of symptoms, and the number of days before symptom relief. The trial was conducted over 90 days. Results showed statistical significance in all 3 measures. Echinacea plus herbal tea was significantly more effective than the placebo at both reducing the duration of symptoms and providing relief faster than the placebo. There were no adverse effects mentioned in this study. However, the majority female subjects was a limitation of the study, and therefore data would not reflect the general population. The final study I reviewed on echinacea considers its effectiveness, safety, and tolerability in children. The sample size of this study is low, but I thought it was important to review as it was the only one I could find with child subjects. 11 children aged 2 to 12 years old were recruited by the Canadian College of Naturopathic Medicine by placing posters in a local clinic. Parental or legal guardian consent was received. The study was conducted by completing a preliminary examination at baseline and one 13 days later. The examination included medical history, current and concluding respiratory infection symptoms, and a physical examination of the general condition of the child. Symptoms were also recorded using a 10-point Likert scale. The subjects were then given Echinogard, an Echinacea purpurea-based solution in the ratio of 1.7 to 2.5 to 1. They were instructed to give age-appropriate doses of 2.5 milliliters 3 times a day for 10 days for 2 to 5-year-olds, and 5 milliliters 3 times a day for 10 days for 6 to 12-year-olds. Parents were also instructed to keep a diary of symptoms, adverse events, and return remaining solution at the end of the trial. On day 13, children received the same preliminary examination and differences were measured. After the second examination, results showed a significant decrease in severity of symptoms after 10 days of Echinogard use. 6 subjects rated the tolerability of Echinogard as very good, while the remaining 5 rated it as good on a 4-point scale. Compliance was very high. There were no adverse effects reported by the subjects or their parent or guardian. Adverse effects included rash, itch, asthma, or asthma-like symptoms. In conclusion, Echinogard, an Acacia purpurea alternative therapy, was both safe and effective in treating respiratory tract infections, evidenced by no cases of adverse events or side effects, as well as reduction of severity of symptoms after 10 days of treatment. Based on the 3 studies presented, Echinacea is an effective therapy at relieving flu-like symptoms, reducing duration of symptoms, and providing faster relief of symptoms. Tolerability in each study was high. The only complaint was of taste by only 3 subjects in the child-focused study. There were no adverse side effects reported in any of the studies. However, as mentioned earlier, because of the type of flower echinacea derives from, those with allergies to flowers in the daisy family or ragweed should avoid echinacea. Administration of the therapy ranged from a hot drink of concentrated syrup dissolved in hot water, tea, and a syrup solution. No form of administration seemed to be more effective than the other. Dosage of echinacea varied. In one study, participants drank a single dose which had the equivalent of 1,140 milligrams of echinacea extract, while the other study used echinacea-based tea, which had 1,275 milligrams per tea bag, and participants were instructed to drink 5 cups per day, reducing by 1 cup per day. Both studies were effective. More research should be done to determine what dose would be effective at relieving symptoms. Overall, I believe echinacea to be a safe, tolerable, and effective treatment for influenza relief. The second alternative therapy I reviewed was elderberry. Elderberries are the fruits of deciduous shrubs of the elder family. The shrubs are native to Europe and parts of Asia and Africa. The 3 most common types are the black elder, red elder, and dwarf elder. Elderberry can be purchased as a syrup, lozenges, extracts, and dietary supplements. Some products on the market include Sambucol and Sambucus, which are sold as cold syrups. And elderberry is often a component in a combination of supplements used to support immunity. It is generally considered to be safe for short-term use. However, special precautions should be taken when considering the plant itself and the berries when they're not fully ripe because they are poisonous and not recommended for human consumption. The use of elderberry for healing dates all the way back to 400 BC, where Hippocrates referred to it as his medicine chest. It was a common therapy before the development of antibiotics. Currently, elderberry is used as a complementary alternative therapy to treat cold, flu, infection, and for immune support. And the mechanism behind its use as a therapy for influenza comes from its anti-inflammatory and antioxidant benefits from flavonols and anthocyanins. Flavonoids enhance production of cytokines, while anthocyanins has an anti-inflammatory effect, which can be responsible for pain relief and fever reduction. And elderberry also blocks the adhesion of hemagglutinin to host cell receptors. This first study is a multi-center randomized double-blind study where researchers tested the effectiveness of elderberry extract in the treatment of influenza A and B. Subjects included 60 patients in Norway who were presenting with early flu symptoms. Influenza infection was confirmed. The participants were randomly assigned to an experimental or control group. The experimental group was instructed to take 15 milliliters of an elderberry syrup 4 times a day for 5 days. The syrup contained 38% elderberry extract with excipients of raspberry extract, citric acid, and honey. The placebo control group followed the same regimen with the placebo syrup. Data was analyzed using a visual analog scale with a 0 to 10 rating, with 0 meaning no problems and 10 being pronounced problems, and was assessed by the subjects at baseline, 4 times daily during treatment, and then twice daily after the treatment ended for 5 days to assess symptoms. The symptoms assessed were aches and pains, degree of coughing, frequency of coughing, quality of sleep, mucus discharge in the respiratory tract, and nasal congestion. Overall, the study results showed that elderberry syrup was effective at reducing symptoms quicker and more efficiently than the placebo syrup and required less use of rescue medications such as nasal sprays, pain relievers, and fever reducers, which were permitted and free to the subjects of this trial. This was evaluated by reported pronounced improvement of symptoms by day 3 in the experimental group versus day 7 in the placebo group. It is of significance to note that there was a significant relationship between efficacy of the elderberry treatment and the amount of syrup consumed. Remaining syrup was evaluated after treatment to determine dosage compliance. This may suggest that lower reported scores were more likely due to decreased compliance rather than decreased effectiveness. There were no adverse side effects reported. This next study was also a randomized double-blind placebo-controlled study which looked at the efficacy of an elderberry extract and was tested on volunteers from a technical college in Shanghai during flu season. The participants of the study were 64 patients who began to exhibit at least 3 flu-like symptoms within 24 hours. They were then assigned a patient number and randomly and evenly assigned to either the experimental or placebo group using computer generation. The experimental group received slow-dissolving lozenges that consisted of a supposed effective dose of elderberry extract in 175 milligrams per dose. They were asked to take 4 lozenges per day with each meal and 1 before bed for 48 hours. The placebo group received slow-dissolving lozenges of similar look and taste with no elderberry extract and were asked to follow the same regimen. Data was collected and analyzed using a visual analog scale where a reported 0 denoted no problem and the highest response, a 10, denoted pronounced problems. Group 1 reported significantly reduced symptom severity by the end of the trial, which was 48 hours. 28% were void of symptoms by trial end, and 60% showed significant relief of symptoms by trial end. Group 2 only showed improvement of symptoms with 16% of participants, while most reported an increase in symptoms and symptom severity by trial end. There were no adverse effects. This study supports the use of elderberry extract in quickly reducing flu-like symptoms within 48 hours of symptom onset with no adverse side effects. This last study considered the use of elderberry in reducing cold duration and symptoms in overseas air travelers. I consider this study because it is a quality research trial and because cold and flu symptoms often overlap. The focus of this study was symptoms, and definitive diagnosis of flu versus cold was not conducted. In this study, 312 economy passengers were recruited who would be flying overseas on a 7+ hour flight and would be staying at their destination for at least 4 days. The participants were mostly women with an average age of 50 years, and participants were randomly assigned 158 to the experimental group and 154 to the control group. The experimental group received an elderberry capsule by the brand Berry Pharma. Each capsule contained 300 milligrams of elderberry extract. The control group received a placebo capsule of similar packaging and appearance. Both groups were instructed to start taking 2 capsules per day starting 10 days before their travel date. After day 2 before travel, dosage increased to 3 capsules per day from the day before travel to 5 days after reaching their destination. Participants in the experimental group were taking a dose of 600 milligrams from day -10 to -2 to 900 milligrams thereafter. This was similar to comparative dosages based on research. All participants kept a diary where they recorded their symptoms, compliance, and completed questionnaires. Measurements included the Jackson score, Likert scales, quality of life, and PCS scores. An interesting result was the PCS scores by the experimental group. PCS scores evaluate physical functioning, body pain, and general health. Participants in the elder group displayed more favorable PCS scores, but the mechanisms supporting this are unknown. Ultimately, the data revealed that elderberry was effective in reducing the length of cold episodes by an average of 2 days and decreased severity of symptoms compared to the placebo group. There was no significant evidence to suggest any protective factor of elderberry. There were 5 cases of adverse events. However, after unblinding, some participants were placebo, while no connection could be made with the other cases. Further research should be conducted to understand the mechanism behind greater physical health by those taking elderberry and the effectiveness of elderberry on cold and flu symptoms. Based on the reviewed studies, I would recommend elderberry as an effective and safe alternative therapy for the treatment of flu, cold, and respiratory infection systems. The research suggests elderberry to be most effective at relieving symptoms faster and therefore reducing duration of illness by up to 2 days. There were no complaints regarding tolerability. There were no adverse effects that were significant, and therefore I would deem the use of elderberry as safe. Administration of elderberry was by capsule, slow dissolving lozenges, and syrups. Dosages range from 600 milligrams to 900 milligrams per day. There was no evidence to suggest higher efficacy between administration or dosage. One study considered the prophylactic use of elderberry in air travelers. Air travelers are at increased risk of cold and flu. However, the data did not support any significant evidence to support its use as a prophylactic. I believe more research should be conducted on the prophylactic use, dosage, safety, and efficacy of elderberry as preliminary research seems promising. Overall, based on the research, I would consider the use of either echinacea or elderberry in the treatment of seasonal influenza, respiratory infection, and even cold symptoms. Although there is little evidence which supports the use of either therapy prophylactically, there are immune support vitamins on the market that I would consider safe as a preventative measure. The studies presented provided efficacy to support the use of echinacea and elderberry to relieve flu-like symptoms and reduce duration of symptoms when taken within 24 to 48 hours of symptom onset without side effects of prescription medications such as antiviral medications. Overall, the tolerability of both therapies was pretty high. The only mention of issue was in the child study in which some subjects complained about the taste. Syrups and extracts of both therapies are described to have strong flavors, in which a capsule may be more tolerable. There were no adverse side effects in any of the 6 studies. Both therapies are generally recognized as safe when taken temporarily as a complementary alternative treatment. Long-term safety is inconclusive as there are no studies to support it. However, special precautions should be taken for the use in children and pregnant and breastfeeding women. Some websites suggest it is safe, and some products are even marketed towards kids. One study I reviewed found no adverse effects and supported that echinacea was safe for child use, but I would err on the side of caution. Those with allergies to ragweed or flowers in the daisy family should not take echinacea, and special precautions should be taken with elderberry as the plant and raw berries contain cyanide and can be harmful to humans when consumed. Both therapies are convenient and inexpensive. They can easily be purchased online, through health food stores, and in some cases most general stores. They may be potential cost savings too by avoiding medical visits and relatively lower cost of available products versus prescription medication. As with all supplements, there is a wide range of quality and available products. Consumers should do their research and buy from trusted brands and consider the dosages per serving and cost per serving. I found Gaia, Nature's Way, and Now Foods to have highly rated products. I believe both of these products to be effective. However, dosages in the studies are all over the place and there are no clear recommendations for the amount that would be effective. Further research needs to be done to determine the correct dosages and potentially the difference in effectiveness between available forms of each therapy. Finally, one of the supposed benefits of natural therapies in this case is the possibility of antiviral prescription medication to become resistant to new strains of influenza. Some research suggests that the antiviral antibacterial properties of elderberry and echinacea may prevent resistance. If future research supports the effectiveness of these therapies without possibility of resistance, this could be a saving grace for a possible future epidemic. Most of the research I came across for the treatment of influenza is focusing on supporting your immune system and substances with antiviral, antibacterial, or anti-inflammatory properties. One can support their immune system through leading a healthy lifestyle with a balanced diet, regular exercise, and good hygiene practices, and preventing the contraction and spread of germs. Some antiviral, antibacterial, and anti-inflammatory substances which get a lot of attention are honey, echinacea, elderberry, ginseng, and vitamin C, D, and zinc supplementation. When looking at atopic dermatitis, according to the National Eczema Foundation, alternative treatment options focus on moisturization, antibiotics, antipyretics, and anti-inflammation. There are multiple lines of defense in the treatment and prevention of atopic dermatitis, and skincare is often considered the first line. Using antibacterial and anti-inflammatory oils and moisturizers such as coconut and sunflower oil shows some promise. The second method of defense is internal. There is a high association between food allergies and atopic dermatitis. Therefore, avoiding the major allergens following an anti-inflammatory diet or even a gluten-free diet has made a difference in some who suffer from eczema. I would conclude there is some promise in the use of antiviral substances for the treatment of influenza and the use of allergy-friendly diets in the treatment of atopic dermatitis. As always, research is needed to support all possible complementary and alternative therapies for both diseases. Thank you for watching our presentation on atopic dermatitis and influenza.